Good morning, everyone. It's such a pleasure to introduce the work and members of our Interdivisional Task Force on the pandemic. In March of 2020, Dr. Charles Findlay put out a call for trauma psychologists to work with him on a task force to help psychologists learn about trauma and how to help people suffering from trauma due to COVID. Soon, over 100 psychologists and over 13 divisions of the American Psychological Association answered the call. We soon formed subgroups representing specializations within our larger group, and each subgroup began to collect and disseminate resources to help those in need. Over time, we learned creative ways of collaborating, especially interdivisionally and intergenerationally. We reached many people both here and abroad. We've collected our lessons learned and hope that they help other mental health professionals face future pandemics. In this presentation, you'll hear from chairs of some of our hardworking groups who will present the findings of that group. Here is a slide of those presenters. Here are the presenters listed in order of the presentations. Dr. Charles Findlay, Dr. Lorraine Walker, Dr. Maureen Riley Landry, Dr. Arlene Steinberg, Dr. Areep Felsin, and Dr. Falou Rami. The first presenter will be Dr. Charles Findlay, speaking on the APA Interdivisional Task Force on the pandemic. Thank you.
You need to unmute.
Okay, welcome everyone. I'm happy to be here. We're all happy to be here. I'm the chair of the task force, and let me get right into the presentation. This session is chaired, of course, by Dr. Serlin, who just introduced us. She brought us all together and to provide a perspective on what we're doing collectively as psychologists who are active. And from its inception in late March of last year, APA Interdivisional Task Force on Pandemic has been operational, and doing some very busy. By the end of summer, 14 APA divisions signed on as co-sponsors of the division, with the APA's newest division, Division 56, as the lead division. So we have some specific goals, relatively limited, but among other things, the task force has been translating what we are finding during the pandemic to post-pandemic action. Certainly, we're trying to help as many people as possible during this period of time, but we want to especially be ready afterwards. So best practices are emerging from the 10 working groups that will be noted today. One of the nice things that have come out of this is Oxford University Press wanting to publish our task force book. It's co-edited I'm co-editing with Lenore Walker and Eileen Serlin. We expect a contract by the end of the month and delivering the book of our work by the end of the year. We'll see how that goes. So in this particular session, I would like you to look for cultural diversity of traumatized clients, because we are touching lots and lots of different groups at different times. Best practices in treating COVID-19 challenges is what we're especially interested in, especially social isolation, dealing with anger and frustration due to changes in public health rules, social distancing, mask wearing, among other things. there's a new theories, treatments, and innovations in client management has emerged so far from our work. Also in this session, I hope that you'll be looking for issues that have come up every single Friday that we meet as a task force. This session and the book will be an interdisciplinary, cross and multidisciplinary, multi-generational, and action-oriented, just as the task force has been. This session, this book, and task force are all attempt to be integrative across generations, cultures, methodologies, and media. So hopefully you will join us, the APA Interdivisional Task Force on the pandemic, by contacting any of us, and you see our emails there. So pause it, write it down, join the task force. Eileen?
Thank you, Charles. Thank you very much for this introduction for the rest of us to the task force. And let's go back to the screen share now. And the next presentation is by Dr. Lorraine Walker. So I'm going to.
Okay. Hi, everybody. I'm happy to be able to talk to you about one of the early working groups that has been going strong since April of 2020, and that's the COVID IPV, or interpersonal violence group. We knew that there was going to be a rise in violence because people were being ordered to stay home, and many of them staying home with people with whom had high rising tensions and had used violence before. We had no idea that it would rise to 3 times the rate of reporting, and we had no services. Because most of the courts have shut down, most of the battered women shelters for those with interpersonal violence shut down. We had no idea what was happening to children who had been abused or to people who were being sexually abused. We did know that sexual harassment in the workplace probably was going to lower, because most people started working from home rather than working in offices. And that is exactly what happened. So right away, we had 10 people who jumped on our subgroup as soon as Dr. Findlay formed them. And within the first time we all met together, a diverse group of people. Some of them were newly licensed people, some were students, some were like myself, been around for a while doing this kind of work. And we were really representing a whole bunch of different diversities of lesbian, gay, transgender, bisexual, and questioning people. We also were looking at people of different racial groups and ethnic groups. So that was very exciting, even with our small group. And as we began to grow, which we did very quickly, diversity continued to be a very important part of the work we were doing. We immediately, our younger members, not necessarily in age, but certainly in their skills in working social media, immediately formed a Facebook page, an Instagram page, a Twitter page, and other social media that I don't even know which ones were being used, so that we could disseminate the information that we were collecting as quickly as we could. As we began doing this kind of work, violence started erupting around the United States and some of it around other countries in the world because of the racial tensions that were exploding from police and other kinds of inequities. So you can see our task force was dealing with a lot right from the beginning. One of the, we tried to find different ways of disseminating in addition to the social media, as well as trying to use some traditional means. But we found a new way to try to get the information out very quickly, especially to other mental health professionals. And that was the creation of what we called roundtables. Every Thursday from 12 to 1 o'clock Eastern Daylight Time or Eastern Standard Time via Zoom. Our group would get on Zoom, so we'd see all of us in boxes. And we would then have Facebook Live discussions. And soon we would end up inviting Dr. Eileen Serlin's group, the whole person approach to psychotherapy group, and they joined on as well. And so we really began to have a plethora of different kinds of information and ways of dealing with the rising tensions, the rising amounts of violence for people to experience and for other therapists to experience. Being on Facebook Live gave us the opportunity to reach the average person who was also struggling, as we were struggling, with learning how to live with this COVID pandemic. We would do 5 to 10 minute presentations that would just stimulate discussion. Although I have to say that our group was so great that they didn't need much stimulation. And we had wonderful, we now have about 35 different roundtables that are archived, and we have a YouTube channel as well with a variety of different topics. I'm going to show you a few of them just to give you a sense of how exciting it was and the kinds of information, because we had people jumping on our Facebook page from all over the world. We had people on our Zoom call from Madrid, from Israel, from Spain, and we had a woman from Uganda who's doing the work there who jumped on as well. And we kept adding people and different people at different times. So let's take a look at some of what we've been doing. Here you can see a kind of screenshot of us as a group. Spend a lot of time talking about how to protect yourself. And one of the main ways is to leave the situation when you see it escalating. We cannot do that during COVID-19. Unfortunately, most of the battered women's shelters are not taking new people across the world. And we know at the same time, being locked into your house with an abuser has increased domestic violence incidents at least 3 times. That's what's being reported now, triple the number of people. And before that, we knew that in at least 20% of homes, and I often said it's 1 out of 2 homes, there's going to be some form of physical, sexual, and or serious psychological abuse. So what are we going to do if we can't leave safely? Well, the first thing we're going to do is we're going to pack a bag, and we're going to put some of the important papers and some of the kinds of things you might need if you end up being hurt despite everything you do, and you have to go to the hospital or seek some other legal remedies. But for the most part, we want to try to learn how to de-escalate and not let the violence increase, the abuse increase. And the best way to do that is to recognize it when it occurs. So you can see in that particular presentation, I was talking about some of the newer techniques that we were giving advice on, but after I talked, other people joined in who were on the screen to talk about some of what they were finding in their clients as well. And by the end of the hour, we were ready to go over so many times because we had so much to say. Here are some, I'm showing you Laurie Gill, who's one of our members on the group, and she's teaching us a technique on how to deal with anxiety, and then we all practice it, and then we suggest that people who are watching also practice it. So let's see if we can get this one to play as well.
What I'm looking for. If I'm
Lovely. Thank you so much.
Welcome.
Well, that skipped her a little bit.
About some very anxious clients that I've worked with, that when I gave them very general instructions, they have found difficulty, and I've found sometimes it's helpful to talk with them and even suggest something like, how do you feel? In Israel, we have lots of beaches, being on the beach. Can you imagine yourself on the beach by yourself, feeling the sun beating down? Is this a good thing for you? Some people even have suggested, can you imagine yourself floating on a cloud, about supporting you and carrying you, or a feeling of coolness or warmness? And I've done work with families, and sometimes it's helpful to try and get, like, I talk about family government, that we sit down and we discuss together how we can each find a particular place and maybe have some agreement that we have a group time out when people feel things, tension building. Somebody say group time out, and everybody goes to their safe place for a couple of minutes.
With clients, especially clients who are very anxious, before I do the visualization exercise, have them come up with a place so that they're not doing it in the moment where it's really unstructured and it can create some more anxiety, but to actually have them before we do the exercise, kind of identify a place.
To add to that, I love that kind of prep is something I also do with clients when doing safe space. And it can, what I found too sometimes to be really helpful is take a SUD scale before and after, because sometimes, right, the safe space is actually not safe. And so I find when it can be really hard to get into that visualization and feel a sense of calm, to kind of unpack, is that actually really a safe space?
Explain what SUDS level is.
Yeah, so subjective. Yeah, so subjective unit of distress. And so it can be helpful as a way to help clients, and then you as the clinician kind of monitor, is distress increasing or decreasing? So 0 being no distress, 10 being the most amount of distress that you could possibly be in. And so when you're doing some of these activities, it can be really helpful to do kind of a, from 0 to 10, how are you feeling now? And then after, from 0 to 10, how are you feeling now?
It's also the body scan, to do a body scan so you know how you're feeling actually in your body. So if it matches, like, oh yeah, I like it, it's quiet, or it's a safe space, but your body is telling you something different. So you have to change it.
And safe space can change over time, like at different times. It doesn't always have to be the same safe space that you go back to.
One of the things that's fantastic about all of the calming and the stress reduction and the safe spaces and the safety building is that, it's very empowering. And for survivors of intimate partner violence, we know that empowerment is such a critical piece to build up that empowerment and that control. Little by little, and those even who are still living with abusive partners, to be able to take that little bit of control, as you said, Michaela, in having a mobile safe space or like a mobile safety pack, or to be able to go to this safe space in our mind and have that bit of control kind of as we go. But as you pointed out, as well as so many have pointed out here today, it generalizes to all of us so well right now in this chaos that we're living in across the world, right? We need that empowerment, and we need to have those little blips on the radar, those little pieces in our day where we can take some control back and have a little bit more of that power. It's very, very healing.
So you can see how we all jump in. It's very informal, but filled with really good information from people who are in practice with a variety of people in a variety of places. We represented so many different countries as well as places across the United States. Let me try Lori Gills again, because I'd like you to see it. It's really her great presentation.
actually, I don't know how well you can see. I don't think I can get the camera all the way down, but vigorously shaking it out, right? My hands are shaking and it's coming all the way up my arms. So if you're able to stand, if you want to try this, and just vigorously, we're really releasing that excess energy. This is great to do when our body feels jittery or nervous or shaky. It also wakes us up a little bit too, but it's great for discharging that excess stress. Stomping, right? Kids naturally do this and we often want them to stop, but I much prefer this to the self-harming or, the other things that happen when that energy builds up. So we want to externalize. And another is a Qigong approach, and it's just bringing our shoulders up. Be conscious of this if you have shoulder pain. And as we breathe out, we're going to push our hands down and go, so breathing in, breathing in. So you can give an audible sound or just a breath, whatever feels comfortable to you, but just noticing. So those are some activities for discharging. Great.
So you can see we practice as well, and we've learned through the joint work with Eileen Serlin's group that psychotherapy isn't just verbal, that there are many different creative ways that we can help people heal from trauma. And when you're working with a very multicultural and diverse group, you want to be able to use nonverbal techniques as well. And let me just see if we can do this one. And we'll talk.
If I'm sitting and looping in the pain and in the fear and in everything that just happened, that's going to reinforce that affective state. So I often use a technique called name it to tame it, where we'll notice what we're feeling, right? Name it, I'm feeling really terrified, or I'm feeling really overwhelmed, or I'm feeling really hurt, right? Allow it to be there as part of the human experience, but then maybe incorporate a strategy that's going to reinforce where we want to be. So where we want to be headed. So if calm is what I'm aiming for, I'm going to gravitate towards a technique, a message, a visual, a somatic response that brings about that sense of calm. And we want to practice returning to that when the activation comes up.
So I hope that you get a sense of the kind of work that we have been doing. We've also been looking at some of the apps that have been on people's cell phones, because many people have had the ability to use a cell phone, even if they don't actually have a computer. And so we've looked at some of the free apps, and we've looked at some of those that cost money, and tried to get some sense of how to use them as adjuncts to psychotherapy. The one I put up here, the PTSD coach one, has been created by the Veteran Administration's National Center for Post-Traumatic Stress Disorder, and the VA has a number of excellent apps that people can download for free, and therapists can learn them and use them to help clients in between the sessions that we work on. Oops. Here's the Calm one. This one you have to pay for. A lot of our clients like it. It's $12.99 a month right now, so that's a little pricey for some people. But for those people who want it, people do say that it works well, but together with therapists. It does not actually substitute for good therapy. So what are our future goals of our task force? Well, we're going to continue with the roundtables. We've taken a little hiatus for the summer because we're all taking well-needed vacations that we need. In fact, I'm leaving for my Denver vacation after we do this video for everybody for APA. We're downloading and categorizing these roundtable talks so that people can go to them and just click on ones that you might want to look at. Like we have some on eyes fatigue, how do we deal with that? We have dance therapy, we have creative art therapy. We have experts from all over the world. We just finished looking at virtual therapy from Skip Rizzo, who's one of the creators of the virtual therapy, reality therapy kinds of tools. And of course, we're working very hard on preparing our book chapter for Dr. Findlay's pandemic psychology book that we're working on. And as Dr. Findlay suggested, we're looking at making sure we don't get caught short in the next pandemic, should there be another one, which there probably will be because of all the health issues going on. And so we're trying to find ways to make sure that mental health workers are prepared, because most of us were unprepared and most of us have been dealing with these issues. So with that, I'm going to turn it over to my colleagues, and I hope that you have gotten some sense of how we've been spending the last year and a half together. Thank you.
Thank you so much, Dr. Walker. What a wonderful, enthusiastic, and interactive presentation. So let's see about going to our next one here. And we have Dr. Maureen O'Reilly Landry, who's going to be speaking on the group called Hospital Healthcare and Addiction Workers, Patients, and Families. Let me bring her back up on the screen. Dr. Walker, Dr. O'Reilly Landry, here you are. There you are.
Okay, so my remarks right now are going to be very brief because we're going to be presenting a video. Just a couple of things. One is that our name has evolved, and as we added in more populations to address, it got unwieldy. So now we are officially Medical and Addictions Working Group. And Patricia O'Gorman is my co-chair. One note is that I found out just shortly before presenting here that some of the letters that go after Adam Kleijik's name are inaccurate, so they're going to be changed. And so he wanted to be referred, he's a doctoral student at McGill, but he has a lot of military and emergency experience. So now I think we can just start because it's all in the video.
Thank you so much. Let's get back here. And here we go.
Hi, I'm really thrilled to be able to tell you about our incredible group, the Medical and Addiction Working Group of the APA Task Force on the Pandemic. Our mission is to reduce or prevent COVID-related psychological trauma and to support resilience and growth within the medical and addictions communities. We've been collecting educational and training resources and now have our own website and blog. We focused at first on the professionals in COVID hospitals, especially those in emergency rooms and intensive care units, the people rightly described as heroes. But we're also mindful of the unsung heroes, such as housekeeping and food preparers. These essential workers were putting their own and their families' lives at risk, but were often invisible to the outside world. And of course, feeling invisible can be a trauma unto itself. Then we imagined what it must be like to be a hospitalized COVID patient and to experience the double trauma of having a serious life-threatening illness compounded by forced isolation, or to be a family member unable to be with them at this important time. So we included patients and families. And finally, we wanted to help healthcare leaders to lead in a psychologically informed way.
Last summer, I was working with a physician in Korea about trying to figure out how to utilize her materials in both Korean and English to be able to use on our website that we were in the conception of thinking about having that now we have. I began to also increase our knowledge here of addiction, changing actually the name of the work group as to include addiction as we all began.
Does everybody have audio?
No.
Yeah, I don't have audio.
You're muted, Maureen.
Yeah, do people have audio?
No, I don't have audio.
No.
This is Iri.
Ever since Patricia started speaking, I haven't gotten audio. And I'm not controlling this, so I don't know what to do.
This is tough. I know.
Any scabs they had of their healing up until this date. And now we're being re-traumatized by just what life had to offer them. In all of this, I gained incredible insight and compassion and support. Many of my family members are Asian. I've required and received much support from our group about dealing with the whole Asian hate issues. This has been an incredible journey, and I invite you to look at our materials and to join with us.
Now, a bit about how we got started. I'm a medical psychologist with a husband and son working as physicians in a COVID hospital at the end of March 2020. I was very worried about the toll this would have on them and wanted to use my knowledge of psychological trauma in medical settings to contribute what I could. I asked colleagues in APA, how do I join the APA COVID task force? When they couldn't find one, they decided it was a great idea, and the trauma division immediately took the lead, and now here we all are. I'm so grateful to the trauma division for doing this because it has afforded Patricia O'Gorman and me the privilege of leading what is truly the most impressive group of human beings I've ever known.
I'm a PhD in health psychology, trauma expert, and associate professor at the Universidad Complutense de Madrid, and a clinical psychologist, a specialist at the Hospital Clínico San Carlos, at the Child and Adolescent Mental Health outpatient unit, and also at the trauma adult unit at the hospital, also outpatient. I run a couple of humanitarian projects in Uganda, thanks to EMDR Spain.
I've been a member of the task force since last year, and where I serve as the representative of Division 38, the Society for Health Psychology. And it's been a really great experience to bring health psychology's knowledge to the task force and share the connections between trauma and health conditions, and also to participate in the organization of the blog and the website and the great work being done there. But the thing I'd like to say most is just how much I've enjoyed being part of this group. It's such a wonderful, mutually inspiring and supportive group, and I've been really happy about that. I'm happy about the future of the group and where we're going with it.
When the lockdowns and quarantines were put into place as COVID swept the world, the shockwaves of anxiety, stress, and uncertainty affected even the most resilient of workers, and the need for those serving the public to have spaces for support and assistance became apparent. My work over the last many months have been focused on providing resources, information, and telesupport for those working in organizations that help provide healthcare and mental health services. I helped organize and provide through members of the Georgia Psychological Foundation 3-minute podcasts for the public, which are playing now on a local radio station called Mental Health Moments. We have tackled issues around coping with the pandemic and support ideas. So far, there's been 11 podcasts and more being planned. In addition, I helped develop an on-demand PowerPoint presentation for psychologists, and the leadership of GPA held multiple town halls. Services were provided to the nurses through the Georgia Nurses Association and school nurses through the Savannah-Chatham County Nursing Association. The Georgia region of the American Red Cross provided twice-weekly Zoom telemeetings to staff and volunteers. We came together as psychologists do in very difficult times, and the opportunity to serve felt like a gift.
I'm an IT professional, an author, and a survivor of childhood sexual abuse. I got connected to the working group through Dr. O'Gorman, through a self-help book that I'd recently published to help survivors of abuse and assault build resilience and overcome their trauma. And she invited me to participate in the working group by writing a series of blogs to help survivors deal with the overwhelm of COVID. So this included information on different breathing techniques, visualization techniques, learning about yoga, and engaging in expressive arts like contemplative photography. So my goal was to help everyone out there who is suffering from overwhelm, particularly survivors, be able to have techniques at their fingertips that they could use, and also techniques that they could build long-term to support them ongoing through COVID and into the new world that we're facing.
I'm an expatriate Indian psychologist currently residing in Qatar, and I wear multiple hats as I navigate between my roles in private clinical practice and the corporate world of workplace mental health and well-being. Safety in aviation has often been compared with safety in healthcare. And given my background as a clinical and aviation psychologist in commercial aviation, I couldn't help but reflect on the importance of staff morale and well-being for effective healthcare operations, and the need for resources and supportive space for healthcare professionals during these challenging times. So I worked on a connect, educate, and empower approach to connect staff with peers, enhance knowledge on relevant mental health topics, and provide access to individual support as needed. The government mental health services team in Qatar were keen to engage in this initiative. So when I heard about the vision of our work group, it perfectly fit. So there started my journey as the technical glue, as I'm quite often referred to by members within the work group, to connect our work group members across different time zones and support in collating resources for our website. Recently, I facilitated support for mental health professionals in India as part of my involvement with the Professional Support for Psychologists work group, and I was able to gain from the expertise of the medical and addictions work group members, as well as from the resources that we collated together as a work group to facilitate some of those discussions. Given the current pandemic impact in India, physicians there have reached out for support, and we as a work group are looking forward to engaging with them and connecting with them.
I've been able to incorporate my experience as a special operations combat medic and the deployments which constitute my firsthand work with those in their most desperate and usually last moments. My current work in rescue and emergency medical services in rural New York allows a more nuanced and faceted perspective, augmented through this group. Not only has this group enveloped my own heart, I recently learned that a blog article by a fellow member, Dr. Robert Gordon, "Why Am I So Tired? Managing Fatigue During the COVID-19 Pandemic," was a required read and sign article at a large nursing home for all staff. Finally, as a doctoral student in cognitive neuroscience, it has been immensely rewarding to utilize as much from my education as this task force has given me, and perhaps more importantly, purpose. Let's keep moving humanity forward.
Existential and humanistic perspectives have been a very effective intervention during COVID-19 in a series of 5 Psychology Today blogs, including existential interventions during COVID, the importance of self-compassion and kindness, sustaining pediatric hope, how to deal with compassion fatigue and cognitive flexibility and resilience during the COVID transition. I've incorporated these principles. I realize the importance of the values of humanistic and existential perspectives, including self-compassion, the importance of hope and kindness during this time, and also the importance of confronting one's own mortality and vulnerability. I've greatly appreciated the support, encouragement, and expertise of the COVID task force, and it's been one of the valuable post-traumatic growth experiences during this challenging time.
As part of those collaborative efforts, we are working hard to understand better the experience of collective trauma during the pandemic, and as we move forward in the upcoming months. Together, we will be working on a position paper that will focus on equity and full realization of the right to mental health across diverse communities, increasing equitable access to mental health services and psychosocial support, and building palliative environments that will help to relieve suffering and foster resilience. Finally, I will mention the need for a chief psychologist in the Biden administration to help shape policy, interdisciplinary collaborations, and to expand trauma-informed care and palliative care workforce education and training for psychologists, allied professionals, and all healthcare workers.
Our blog is called Psychological Trauma, Coping and Resilience, COVID-19 and Pandemics. It's published under the auspices of Psychology Today online. The primary goal of the blog is to provide people with tools and resources to cope with and potentially grow from the many varieties of psychological trauma wrought by COVID-19 in medical and addiction settings, which also extend to patients and families. Blog posts are written by group members with an occasional guest author. Here are some posts from different points in the pandemic. Early on, we had the psychological trauma of having a loved one in the ICU. As the gravity of our situation became more apparent, posts included suicide by intentional overdose in children. Recent topics reflect current concerns as we transition back into the world. The return to school, tips for parents of anxious children. Arabic translators have requested permission to translate articles into Arabic, which we're very excited about.
As co-chair and founding member of the NISPA Special Interest Trauma Group, as well as of the Disaster Relief Network. Together, in collaboration, we're providing services, trauma services, pro bono to anybody seeking help during this period of time. I just would like to share how moved and touched I am by this group and what a safe and holding, containing environment the group has created for us all. To do this work, we all need compassion and nurturance, and that is truly one of the biggest resources that this working group is providing to all of us. Thank you to all, and again, it's a real privilege to be part of this tremendous task force.
Okay, well, thank you. And I just want to make one comment that I really wanted to do a video to highlight the abundance of talent in our group. I didn't, because it, as you can see, it goes way beyond me and way beyond the co-chairs.
Thank you so much for a really beautiful and moving display of what's going on in your group. And now on to the next. The next is a presentation by Dr. Arlene Steinberg, who is chairing the drop-in professional support group during a pandemic.
The Professional Support for Psychologists group, otherwise known as the Clinician Collaborative Work Group, was actually initially begun by Melissa Wasserman, Julian Ford, and then Judy Alpert and Eileen Serlin, Tina Narotra Balachandran, myself, and others joined. We envisioned this as a drop-in group for psychologists to support one another in our work and our lives. We envisioned ourselves as facilitators and even co-participants in the groups as we all experienced this shared trauma of COVID-19. While the groups were initially scheduled many days of the week, the schedule cut back to once a week as the need for them lessened. The groups then expanded to provide support more recently, as Tina just mentioned before, to clinicians in India as they currently find themselves in the maelstrom of COVID-19. The groups in India are ongoing and are going to continue for the near future. We'd like to now turn to those that facilitate the groups, who will describe how these groups developed, their experiences, observations, helpful aspects, challenges, and future implications of these groups. Thank you.
In recognition of the contributions and impact of COVID-19 on mental health providers, the APA Interdivisional COVID-19 Task Force's Professional Support for Psychologists Working Group began hosting free weekly meetings to provide an informal supportive space for mental health clinicians to join and connect during the pandemic. These meetings were referred to as the Clinician Support Collaborative, in which mental health professionals, including psychologists, social workers, marriage and family therapists, psychiatrists, trainees from all over the world joined to discuss the challenges they faced and to receive support. Some examples of themes discussed in the Clinician Support Collaboratives include personal and professional isolation, work-life boundary management, challenges that arose in the context of shared traumas and shared stressors, anxiety of the unknown, the concern about the possibility of returning to in-person practice, secondary traumatic stress, compassion fatigue, and compassion satisfaction, and managing Zoom fatigue. More than 50 collaborative sessions were held since the meetings began in May of 2020, and we received positive feedback from attendees and participants. These meetings were organized via Google Meets, and guidelines, including a disclaimer, were developed in conjunction with legal support. The guidelines included the acknowledgement and understanding of the participants that the meetings were not intended to provide psychological services and were not to act as consultation or supervision. Rather, the group leads were donating their time to coordinate a supportive community of mental health clinicians during the pandemic. We engaged in outreach and recruited participants via listservs and social media platforms like LinkedIn, Facebook, and Instagram. Participants from all over the world joined in on these meetings, including mental health clinicians from the United States, Qatar, Kuwait, India, Bangladesh, and Argentina, just to name a few.
The Clinician Collaborative provided an opportunity for fellow mental health professionals who joined us to share their thoughts, feelings, and emotions They were all dealing with normal reactions to an abnormal time and situation, and the group provided a space for normalizing without minimizing their experience. Participants shared and discussed the challenges that came with the loss of support and contact with colleagues, transitioning to telemental health services, managing work-life boundaries, the experience of shared trauma, personal losses, the physical and emotional exhaustion, and empathy overload. And we often reflected on maintaining therapeutic boundaries among various other themes. It was humbling to witness mental health professionals from different walks of life come together with an openness to provide resources and learn from each other. The sharing of knowledge and experience also helped in mitigating some of those feelings of isolation, and it helped foster a feeling of camaraderie as we adapted to the new normal of both personal and professional life.
So the question I want to address is, what was most helpful? And as I think about that question, I ask another question: helpful to whom? In my mind, there was no question that the meetings were helpful to the attendees. But to my surprise, there was an additional benefit, and that is that they were helpful to us, the organizers, the ones who provided the space. How were they helpful? First of all, we as mental health professionals just simply like to help. That's why we entered the field, or at least one of the reasons we entered the field. Second, the meetings were helpful to us in that we shared the same trauma that the people who attended the meetings were sharing. Those who attended our meetings were dealing with the very same issues that we were. We shared their trauma, we shared their fear, we shared their loneliness, we shared their burden of caring, their concern around work-life boundaries, and we, as they, were overwhelmed. Third, those of us who were attending these meetings and running these groups, we were meeting regularly with each other, and that provided an additional source of support for us. It provided structure because we were meeting regularly. We supported each other, and it provided some validation of shared experiences. And also, there was the additional benefit of younger and older people working together, and each having something quite unique to offer the other group. The younger folk were technologically sophisticated, and the older folk were desperately in need of their sophistication. And the older professionals had more experience in terms of trauma and working. And so we could offer some degree of wisdom, although the young folk were clearly quite wise in these areas as well. So the point that I want to make is that the people who attended our groups felt, I believe, helped by the group meetings, but we felt helped by the group meetings as well. And we felt helped by meeting with each other.
We recently provided clinician collaborative support groups for psychologists in India at the request of a psychologist who had approached a colleague expressing the need for this among Indian psychologists. Immediately, I realized that the groups we had been running during the height of COVID here might be of help to them, and the psychologists in India were most interested, albeit they wanted us to provide not only support, but content as well. Many of the psychologists in India were either in training or teaching. Rather than the drop-in groups that we facilitated before, these attendees seemed to all know one another and seemed part of a cohesive group. We focused on topics of their choice. The groups were also similar to the clinician collaborative ones in their consistent and predictable schedule, which has been helpful in grounding attendees who are going through the maelstrom of COVID-19. The topics have included an overview of trauma, self-care and body-based grounding, psychological first aid, secondary trauma or shared trauma, and grief. The focus of the groups was on providing support, and attendees shared their experiences, with some having lost loved ones. They also wanted to speak of their work and share about their patients' losses and trauma, as well as think together of how to work whilst experiencing shared trauma. As things improved a bit, albeit still difficult, they also spoke of the stirring of past traumas, like the partition and the intergenerational transmission of trauma, both for them and their patients. The groups were also moving for the facilitators as well, who, while things have improved where they are, their own experiences from a year back were readily stirred. The group's holding function has been helpful. Attendees have asked for the groups to continue, and they are ongoing. Indeed, this model for psychologists providing support seems most helpful during a pandemic, perhaps may even be helpful during other times of communal trauma. Thank you.
One of the most heartwarming experiences for me, though, was with this special group of the Indian psychoanalysts who contacted one of our members. And I'm part of a group that's been working with them on Monday mornings. I am a dance therapist and work with kind of embodied ways of working with COVID. We believe that trauma is so much in the body. And they actually were speaking about the pain in their bodies and the kind of the involuted postures. We did some work. We've had 2 sessions so far, and this is continuing as COVID continues to rage in India, although it's coming down some. We did some work with what we call grounding, literally. And the interesting thing about grounding exercises for them is if you ask them to take a breath, it kind of got painful for them and actually reminded them of some traumas about not being able to breathe. But we did grounding, feet on the earth, strength, resilience, and then began to move it into mobilization. And some of them also experienced pains in their arms. They hadn't moved their bodies in a long time, but actually felt good. And then we put on some music. I had some Indian music, and we got up and actually danced. There was some smiles. So that, in terms of bringing some life back, seemed effective. And I look forward to continuing this work with them.
What we took away from this experience was that in the future, when there's shared adversity or trauma, as there was in this case, and this is often the case in disasters and other kinds of mass incidents that aren't necessarily considered to be shared adversity or trauma for the psychologists and other mental health providers, what's really crucial is that there be support for the people who are providing the support. Now, we all know this. We all know the importance of addressing vicarious trauma and secondary traumatic stress. But what we learned in this experience in the Clinician Support Collaborative was the importance of a parallel process. We were able to organize and facilitate leaderless groups with our colleagues where we provided mutual support to one another. We got as much out of it as the other participants did. But in so doing, we also prepared ourselves for the opportunity to provide support to other colleagues, for example, our colleagues in India. And we also provided one another with mutual support just through the process of organizing this whole endeavor and doing it together as a small support group. And that's what we really need to be aware of and think about in the future. That's the kind of parallel process of support for the supporters and supporting those who will ultimately provide further support and training down the line.
And our next presenters, Dr. Reed Felsen, and Dr. Jenny Frumer will present their work now. Okay.
Unmute.
Hello, everybody. It's wonderful to be together at this point, a year and a half after we all came together. So my friend and colleague, Dr. Jenny Furmer, who is the retired CEO of a very large human service agency in Florida, and is now a leadership development and organizational management consultant, and the director of the NOW initiative for Holocaust survivors at the Morse Live Health System. Jenny and I am a clinical psychologist. I'm the co-chair of the NGO on of the trauma working group in the NGO on mental health in consultative relationship to the United Nations. I'm in private practice with a focus on trauma and intergenerational transmission of trauma, and I'm an adjunct professor at Columbia University. We will we decided to conduct an interview with each other to touch upon the main issues that our group sees as its mission and as its goal. So please, Jenny.
Yes, so thank you so much, my friend and colleague, Dr. Felsen. Irit, you invited me to join this work group, and it's focused on older adults and their caregivers during the pandemic. I wonder if you would give an overview of how this group got started and what you were thinking.
So I think that it's really important for all of us. You know, I think we are in a field in which self-reflection and process are as important as what we do with our clients. And therefore, it's very interesting to notice the way that this group came to be, because when Dr. Findlay called us all to join him, we created in the initial meetings a lot of working groups that were dedicated to various populations, which various people thought might have particular vulnerabilities to negative mental health effects of the pandemic. And we did create a significant number of working groups. And when we were done that process, we noticed that we forgot to create a group about the older adults. And that was a particularly sort of odd fact for us to notice, because at the time in March of 2020, the most, I think, publicly advertised vulnerability was that of the older adults. And at the time, the CDC data was showing that they were dying, people over the age of 65 were dying disproportionately more and suffering from more complicated COVID. And I think this was also, it meant that social distancing and all of the negative effects of that, isolation, feelings of loneliness, were much more significant among those of us older than 60. And yet, even though many of us were older than 60 in that group, that initially was creating the working groups, we did not remember to do so. So it was very important for me to try to create this group and raise the visibility of the unique challenges and unique needs of what we now refer to in our group as vibrant older adults who are still very active, working, jogging, doing all those things, dressed fashionably, who all of a sudden were bunched together with the so-called older adults into a category that supposedly is one, but is really so varied.
Yeah, and I think that sort of heterogeneous group and how we lump cohorts together of people who are over chronologically the age of 65 sometimes really hits home with ageism. So thank you for that. The research that you did is really relevant. You were doing some research during the pandemic around older adults. Would you briefly give us an overview?
So what in our group, the way it worked was that each of us was doing different things related to older adults during that time. So I will just throw in there, Jenny, that together and separately, we did a lot of webinars for older adults. My special interest, as I said, was on is on intergenerational transmission of trauma, and so is yours to a great extent. And each of us did webinars for various organizations. Some of them, many of them, organizations of children of Holocaust survivors. And it became very clear to me that children of Holocaust survivors were having their own reactions to the pandemic, very much related and colored by their intergenerational trauma. And so together with a colleague, Professor Amit Shrira from Bar-Ilan University, we conducted a research on samples of Canadian and American children of survivors. And what we found, which was very consistent with previous findings about other types of stressors and life-threatening situations, what we found was that there is a difference in the way that people with intergenerational trauma respond to new, novel challenges and traumatic or stressful situations, such as COVID. And one of the most important things in determining the level of the reaction, of the difficult reaction, the psychological distress that they feel, the subjective loneliness that they feel, is the level of perceived PTSD in the parents. So how, to the extent that the parents are perceived as having continued to suffer from significant levels of symptoms, the reaction in the children to COVID and to a lot, especially to the circumstances that accompanied COVID, the social, cultural, political upheaval that carried a lot of associations to the Holocaust, the broken glass in the streets, police brutality, mobs, the potential of mob behavior, the incredible rise in gun sales. As someone put it, one of the participants, we know how neighbors become murderers. The prospect of potential shortages, all of those things were extremely associative and raised a lot of concerns. And the level of symptoms and concerns was different between those with parents who had PTSD according to their perceptions and those who did not, as well as others, of course, not related to the Holocaust. So we feel that these are very important findings because they speak not only to the situation with children of Holocaust survivors, they tell us something about intergenerational transmission of trauma also in other groups, because research about the children of Holocaust survivors has informed research in other groups, many other trauma exposed groups, like Cambodian survivors of the Khmer Rouge and very many other groups. And so this is important because we are now living in a world in which refugees and immigrants and people who have themselves or their parents been exposed recently to trauma are many.
Yeah. Well, thank you. It is really very relevant. And I think you had a couple of questions for me too.
Yes. So being the past CEO of a large human service agency and being involved in that kind of a health system at this point, I think it would be really interesting if you could share with us your perspective about what you saw within that context of a large health system that is providing services at different levels to so many people. What did you see with your clients? What did you see with the people providing the services, with the staff? If you could speak to that.
Certainly. Morse Life Health System is a really large health system in Palm Beach County, offering campus housing, if you will, assisted living, rehabilitation. There's also affordable assisted living and independent living. And in the community-based services, things like a PACE program, home care, medication management, pretty much all of the spectrum of services that an older adult may need, as well as caregivers. The biggest challenge, probably serving 3,000 people a day, is that even for those who were both on campus, in housing, sometimes paying large amounts of money, if you can imagine, for independent living in wonderful surroundings, and also those in the community, probably their biggest concern for older adults was that our lives are being erased, is sort of that sobering component or that sobering comment that came across on a regular basis. So during this collective pandemic, older adults, as you had suggested, really felt like they were being targeted personally by the media, by people who were sort of trying to stay away from them. And that just really exacerbated the them, they, and us kind of component. Many felt like they were being treated like lepers. You know, people didn't want to really come visit them. And of course, the flip side of that is many people stayed away because we didn't want to infect them. But that isn't necessarily how they experienced the situation. Those in home-based settings were not able to get services initially. The challenge of making sure that they had food, medications, other kinds of services. People went without showering or bathing for a couple of weeks because there was such a, extreme lockdown initially until we sort of all regrouped and could figure out, other than food and absolute essentials, how to provide services. And for clients who are dementia, older adults who are experiencing dementia, we know that they are so dependent on facial cues, and all they saw were, sort of eyes and goggles. And we saw tremendous exacerbated kinds of behaviors, tremendous withdrawal from those who were suffering with memory issues and dementia. Even amongst ourselves, we really missed smiles. So we had to learn those micro kind of facial expressions of the eyes crinkling if someone was smiling behind a mask. And those who were in congregate living really felt like prisoners. They would sort of tell me they would open their door and kind of look out, but literally they were imprisoned in their efficiencies. So food was delivered by people in what they called hazmat suits, leaving trays outside doors, knocking on doors, 24/7, they were alone. Campus security totally locked down. Families were calling panicked. It was really a very sort of chronically critical time that had some overtones of acute despair. So what we were really able to do quite quickly is we tried to connect people to technology. We did have some brave souls who were IT volunteers who went in, taught people how to use their phones other than just answering a phone, learning how to FaceTime, how to WhatsApp. And we also quickly mobilized volunteers so that they could have friendly voices. And you mentioned the staff, and I'm just going to take 1 second to say that staff had to be reminded, the people in the front lines had to be reminded that endurance and grit can be really dangerous without the opportunity for rest and time out. And so we had to remind them constantly, as others that have acknowledged this afternoon, that being on the front lines is absolutely relentless. And so we know that it's not about gutting it out. Resilience is not just gutting out, but rather ensuring to practice self-care and take time to recharge. So we certainly had our hands full in our sort of microcosm of the world dealing with older adults and their families.
So Jenny, I know that we have only a very short number of minutes left, but as we know, trauma in previous phases in life often impacts the way that people experience new traumas, and it also often comes hand in hand with resilience that is forged through very difficult experiences in the past. So what did you see in terms of survivors that you're serving, survivors of the Holocaust, survivors of other trauma, in terms of their responses, resilience and vulnerability?
Yeah, I think we saw what I've learned as a military term is LOSS, which is the late onset of stress symptomatology, usually as a result of some kind of earlier trauma. So for Holocaust survivors and some of the immigrants that we work with as well, what we really started to see were comments, and we heard comments like, you know, what's the big deal? Like, I lived without toilet paper for 5 years. I don't get why everyone's trying to find toilet paper. Or I can eat sawdust and I'll just be fine. However, more disconcerting comments were, after all I went through, I'm going to die alone. So of all the atrocities I saw, I know I'm going to die alone, which was devastating for so many who have had earlier trauma. There was this resurgence, or rather this urgency to bear witness. I have to tell someone my story. Will you write it down for me? Will you tell my children my story? The loneliness was really palpable. There were trauma triggers that were exacerbated because of the environmental and the situational, sort of environmental and situational triggers. There were also these feelings of, I know I can look out the door and my head won't get shot off by an artsy guard. On the other hand, I feel like I'm still hiding in that closet waiting for the Nazis to find me. So we can only imagine the depth of this sort of resurgence and of earlier trauma during this period of time. And one response, and it didn't really fill the gap, was to make regular calls to survivors just to let them know they were not alive, that they are alive and that they're not alone. So it's not possible to go into greater detail right now, but I think we will continue to learn a lot about the lessons of the impact on older adults, those who have experienced earlier trauma in their lives.
Thank you for that. So I know, and I'm getting a message from our colleague, Dr. Serlin, that we are almost up our time. And I'll just want to add that one of the things that we've seen from the study we just completed, and as you said, Jenny, the issue of the loneliness and how important it is to find ways to prepare in the future so that all kinds of older adults in this immense span that now covers this category, from very young older adults who are still active, as I said, and very engaged, but couldn't remain active in the same way that we did things before, and those that you are working with. Loneliness became a very big issue for many, subjective loneliness, and we are going to run another study. We just got the approval of running another study that will help us identify how to help people should there be another situation requiring social distancing, how to encourage and enhance what we call soloism, or what others call positive solitude, how to combat the sense of loneliness with developing their capacity to have that experience of positive solitude, of choosing to find ways to make the time alone be enjoyable or growth promoting, and how to put in place things individually and socially that will allow us all to continue to remain active and to contribute our expert knowledge in a time when we can't do it the way we can do it when things are all well. So we wanted to also say a few words about our other participants in the group, but as we're running out of time, I will just mention that we're very fortunate to have a very senior member who's in her early 80s and is amazingly vibrant, Dr. Safir. And we have a very young member, Dr. Lauren Williams, who just had her baby. And it's a very important aspect of our group to have that range of ages, that range of contributions, and to encourage people of all ages to direct their attention to older adults. Thank you very much. Thank you, Jenny, and thank you everybody else.
And I would just like to also mention that Mary Beth Morrissey, who we heard from earlier in one of the other videos, is part of our group and is incredibly accomplished as a psychologist and attorney in health law and healthcare. And also Tracy Farber, who hails from South Africa formerly, as I do, and she's a psychologist and has done a lot of work on child survivors, those who were children during the Holocaust. Thank you.
So thank you so much, both of you. It was very touching and very important. Information in this came close to my parents were at Morse in Florida. So very touching to me too. And now we will move on to the next participants. Let's go back here. And we have Dr. Falou Rami, who's going to be speaking on her group called Refugee and Immigrant Concerns Working Group. Thank you, Falou. Here we are. Let me get you on the screen here. Good.
Good afternoon, everybody. Thank you so much. It was wonderful to hear everybody's presentation and the work that they've been doing in their various groups. And thank you so much, Dr. Sherwin, for putting together this symposium and bringing us all together. And Dr. Findlay for being our illustrious leader of the task force. So I wanted to start off a little bit with the start of the group. I believe the task force started in April 2020. I know there was like initial calls put out in March, and I was going through the emails yesterday to remind myself of how things started, how the beginnings of our group started, how our groups came together. And I remember Emily had put together a survey to identify what different task force participants were interested in, and also identifying the groups of interest. And Monica Indart, who's the co-chair of this group, unfortunately, who was not able to join today, took leadership of the COVID-19 Refugee and Immigrant Concerns Working Group and expressed an interest in sharing it, and she asked for a co-leader. And I just really liked what she had to say during our Friday task force group. I felt like I had a lot of affinity and similar interests as her. We had shared interests in various groups that we'd worked in, interests in human rights, social justice. I also, when I started off with the group, I was representing Division 52, which is one of the earlier division groups that joined this larger task force. And I also had a deep interest in this group due to my own work clinically throughout the years with immigrants and refugees. But I also did my dissertation on Syrian refugees and through the lens of humanitarian workers that work with them in 14 different countries. So I was really interested in, how their adjustment experiences were shaped through policies, through media, through politics, along with citizens that resided in those countries. So the reason I mentioned that is this all fit, this group that I asked Monica if I could help chair with her. So I already mentioned my interest in international psychology. I have my PhD in international psychology as of 2018. And I was also interested in this group due to my own lived experience as an immigrant and the adjustment processes. And of course, like a lot of the anti-refugee, anti-immigrant sentiment that we're seeing expressed both domestically as well as abroad in Europe and various other countries. And also my experiences as part of the BIPOC community. So all of this gelled for me in terms of why I decided to co-chair this group. In addition, I've done a lot of work in crisis intervention, and I have a deep interest in doing disaster crisis related pandemic work, along with, seeing the impact on refugees and individuals and communities due to armed conflict. So our group has fluctuated and currently includes a core group of 8 to 10 members. And I do see this similar fluctuation in the other group that I chair, which is a crisis intervention and trauma consultation group. And I don't think that that's, I think that's pretty similar from what I've seen in this task force, along with the Division 52 task force that I co-chair. So initially also there was various groups that did not have co-chairs. So our initial discussions of this group were also whether or not we should combine this group to also cover culturally diverse, racial disparities, as well as marginalized groups. This is our mission statement, which has fluctuated as well. I'm sorry, let me try to change this speaker view if I can, because it's really it's throwing me off here. So the mission statement, and then I have some comments that I made on the bottom just to kind of expand on some of our mission statement. So the mission statement of the refugees and immigrant, and if you notice the M is capitalized to represent migrant workers, concerns group, otherwise known as the RIC group, is to work within an interdisciplinary integrative system of care to serve the COVID-related, pandemic-related mental health, as well as psychosocial needs, which is very much a mental health and psychosocial support services term, and advocacy needs of refugees, immigrants, migrants, and related communities. Our goal is to identify and disseminate helpful resources addressing the diverse and multicultural needs of these communities and the harmful effects of marginalization. The committee recognizes the strengths and resiliency of these communities and will continue to find ways to leverage that strength in meeting ongoing needs. We seek an inclusive membership where members of the communities this working group strives to serve are also represented in the RIC working group itself. So only through such full representation can our work be considered fair, just, and equitable. So just to elaborate, it was very important for us when we considered this mission statement along with our working group that we had a community participatory aspect approach. And so that community participatory aspect approach includes, as we mentioned, members of these communities, BIPOC communities, immigrants such as myself, migrant workers, activists, refugees with lived experiences, people that worked at, non-governmental organizations, etc., to be able to gather their viewpoints to fully make this fair, just, and equitable working group. We also, it was really important to include a bottom-up, middle-out, and top-down approach. So what do I mean by that? Bottom-up approach is like the grassroots approach that includes activists, such as what was done in the Interdivisional Immigrant Codepar working group that I'm also a part of, where we as psychologists interviewed activists to find out what have they found to be helpful and incorporating their viewpoints to see how we can help them instead of coming from a top-down approach, a policy approach, a systems approach that's very Western driven, that tends to say, okay, this is how it's done because it's evidence-based versus this is what this particular context in the community needs. And the middle out approach is looking at what are the existing interventions and systems that are in place, programs, organizations that are delivering these services. In addition, as it's already mentioned in our mission statement, it's very important to include resilience and strength, because oftentimes there's a tendency, I'm not saying that it exists in this working group, but there's a tendency to look at particular vulnerable and marginalized group as weak or impacted by trauma, without recognizing the various strengths and resilience that they already have to be able to go through these journeys. And so it's really important to recognize that when we think about coming up with policies and interventions and approaches. And it's also important to look at the role of systemic issues, such as policies and how are resources delivered, how are disparities displayed within these groups and communities. And also, when we talk about fair, just, and equitable, I think it's really important to look at the and be aware of power and privilege and how they influence intervention, services, policies, etc. And I could say from my own perspective, even though I'm an immigrant, I'm of the BIPOC community, I still have power and privilege. I still have access to a lot more resources than others that may be marginalized within that community. I have a higher socioeconomic background. I have a higher educational status, and with that comes power and privilege, which is going to influence my own biases and assumptions. And I think and I use myself as an example, but I think it's important for everybody within this group or working with these communities to be aware of their own biases and assumptions. So we started off the group. Sorry, I'm getting kind of thrown off by the chat. So, it was, we had to have a lot of conversations in this group because there were so many different interests. So we started off with the identification of member interests for the group and which groups. So that in itself was a pretty loaded conversation. And once again, I bring up the biases and assumptions that we all have when working with these communities, because what comes up is the issue of which groups are more deserving versus others. So when I say that, our name changed to immigrants because migrant workers within this group, there was a heated discussion whether or not to include them because of the term migrant. But if we look at domestically what's going on and globally, migrant workers are some of the most vulnerable groups in the United States as well as globally. So that's why we changed our group name to include migrants. And then IDPs, internally displaced persons. And then, so we looked at including citizens and non-citizen status. So there's a natural, what I would like to say is interest in working with immigrants and refugees and IDPs, but definitely with the migrant groups, there was a lot of challenging discussions. And I already talked how those conversations included being aware of our own biases as psychologists, and not only as psychologists, but what are our biases in terms of working with people that have lived experiences or may not have a mental health background, because it's important to include those perspectives when we're thinking about interventions and policies. And therefore, the interdisciplinary, transdisciplinary approach is very important. So the audience that we initially identified for these resources included non-governmental organizations, universities, nonprofits, etc. And then also we had conversations of, do we just focus on groups within the United States or as well as internationally? Because migration and refugees and issues of immigration is very much a key global issue. So we're going to just stay within our boundaries, or are we also going to go internationally to address these issues? We discussed the concept of mapping, so and how to work with refugees. So looking at what exists already, not only domestically, but internationally. What are the gaps domestically and globally? Who's doing what and where? So as you can see, this quickly became quite unruly when we started thinking about what we wanted to zero in on. Do we focus on resilience of immigrants and migrant workers and refugees versus looking at them as victims? We also talked about mapping mental health services around the world. As we know, there's significant disparities both in accessing health resources as well as mental health resources that already exist domestically and internationally, but they've significantly gotten worse when we think about policies and political attitudes that exist domestically and internationally towards these groups, and increased vulnerabilities due to COVID-19. So other topics that came up is how can refugees seriously socially distance when they're living in camps and tents? What about the fact that many of them were getting detained simply for the fact that they crossed the border illegally, for example, and now they're detained, so their actions are criminalized, and they're now at more significant risk of contracting COVID-19 because of the conditions. What's the cultural assignment that's placed on social distancing? What's the resources and barriers? Mental health and health disparities. And we also talk, and then the lack of access to PPE that increase vulnerability for these groups. We talked about leveraging activists and NGOs that are already doing the work, as I had already mentioned. And then some of the resources that we have in our Google folders, webinars, pertinent reports that were really important for us to be familiar with and read, along with articles. So I already talked about our own biases and assumptions, as well as social political views to consider when we're working with these groups. And we were actively seeking greater representation within the group that represents interdisciplinary foci along with international foci. So we actively reached out to activists that may perhaps be interested in presenting to our group. We're looking next month on including activists and people that work with NGOs that have lived experiences. We also, Monica did a great job of including a lot of her graduate students and students in general that are interested in this group, practitioners, academia, researchers, and those along with attorneys. And reaching out to members that worked in international settings so we can also have their voices represented in our group. So we're continuing efforts to engage in the community participatory approach and seeking representation from BIPOC communities and those with lived experiences. I don't know if I'm out of time. Sorry, I'm having a hard time. Oh. Should I wrap it up, Eileen? I'm sorry.
Yes, Falu. Yes.
Okay, sorry, I just realized the time. So that's it in a nutshell. I do have more, but I know that we're limited on time. I apologize for all the time, and thank you for including this symposium.
Just wonderful. Thank you so much. Yes, Falu. It was actually just 15 minutes.
Okay.
Let me just see if there's one more slide to share. And No, we're actually finished with our PowerPoints. So this has been marvelous. And I wrote in the chat, since our time is off, those who can stay maybe 10 more minutes, 5 to 10, just for a little wrap-up conversation among all of us. I'm going to put us in the gallery view. Here we all are. And those who can stay, I don't see all of us here. Yes, Maureen had to leave. So I just want to say, first of all, very personally, that this was one of the best things to come out of COVID for me, is working with all of you. And it's really restored, what can I say, restored my faith in mental health practitioners, such wonderful human beings, and working day and night really on these panels, not just to pull them together, but throughout the year. So much work has been going on. You know, we can just show clips of it, but this represents an enormous amount of work, everybody on this panel. So thank you very, very much. And just any final comments, wrap up thoughts? Everyone is muted.
Well, I'll jump in and say how fabulous it is to listen to what has been going on. We do have these Friday, twice a month, Friday at noon meetings for the entire task force. And we haven't had one for a little while. So it's exciting to hear where people are, where they came from, and where they've gone. I've learned so much, which makes me excited because I have to be one of the co-editors of chapters on the book, and it's going to really be helpful. But I think the importance for the entire profession is to show how quickly we were able to jump in, step up, fine tune our tools, and deliver services in a way that I certainly never imagined doing, and I don't think any of us did. And we held each other's hands as we did it, because it wasn't easy, especially for those of us who are a little bit older. So I just want to tell my colleagues how much I love you all. And for me too, one of the best things that happened out of the whole pandemic was developing this support system that we've been for each other.
Yeah, I'll just jump in and essentially echo what's already been said. For those who haven't been part of our task force and are watching what we have done for the first time, I'm hoping that you'll get motivated. We still can use your help. We're not finished yet. We're actually anticipating working for several more years in this particular area, as long as we're needed. So again, thank you all for doing this, especially Eileen. Thanks so much for pulling it all together and helping us all. Thank you so much. More, I mean, please speak up if anyone else wants to talk, but I just want to make sure that I direct it to Eileen.
Someday I'll get my voice back. And I really sound like. Yes, I want to echo what Lenore said just before we move on. I think one of the real pleasures was how spontaneous this was. No one assigned us. We're not getting credit for it. It doesn't go on our CVs necessarily. We're all past the point where we care what's on our CVs. It was really an act of love, I think, for everybody in this group. And I just so appreciate that.
I just wanted to say that this very session shows the courage, Eileen. I mean, you were so anxious in the beginning, and we all know how it felt from different things we've done through this time, which we never have done before. And look how well you took it on, what courage and what daring, and how now you know how to do it.
Thank you.
And now she's running some of the COVID IPV groups too. since some of our younger people have gone on to internships and other things that they can't, the students their days are just so filled that they can't do them anymore.
No, I think it's remarkable how we see in just those of us who are on gallery view right now, how each of us stretched into ways that we had to, and we did.
Exactly.
I just wanted to say that the Chinese, you guys all know probably, the Chinese symbol for crisis is danger and opportunity. And people change through crises. And, you know, just our own experience and obviously working with others. And there's like no division of like, you know, it's shared. We're all in this, we're evolving and we're continuing to evolve. And, you know, thanks to all of you. I mean, just sort of the group that we formed really, I know personally really helped me get through what was not the easiest year. I had a father who died of COVID in the middle of the year. I had a child whose wedding is about to be rescheduled because of COVID. You know, the life things that we've all personally, and each one of us have had different challenges that we're still going through. You know, as we do the work and also watch, you know, listening to this panel, I knew so much was going on, but I, you know, as Lenore said, I just felt like I learned through listening to all of you talk about the incredible work that's been going on. So, you know, I feel very privileged to have been part of this.
And I want to thank Charles Findlay for our inspiration, our guru, our guide, and keeping us together.
Absolutely. Absolutely.
Yeah, definitely.
Thank you.
I think it's important to stress that, yes, the seniors, of which we're some of us, many of us, I won't talk for anybody else, are in that category. Those of us who have been the vibrant, active seniors that I read and Jenny talked about, face such isolation. For me, you know, being without the ability to get on an airplane and see my grandchildren and my children has just been devastating over the year. And, you know, I'm fortunate we didn't have any major losses. We had a few like other people, but it's just been so important to develop different support systems as we move through life. And this has been a really important lesson for all of us, I think.
Yeah,
exactly. I was going to say, this feels a bit, I hesitate to use the word, but a bit of a family.
Mm-hmm.
We know each other. We've been with each other through the personal and professional incidents all year.
True.
So, and thank you, Jenny, for joining us. We've heard a lot about you. Finally glad to meet you.
And Jenny, you're in my backyard in Palm Beach. I'm in Fort Lauderdale. So we need to find a way to keep our communication.
I think you're muted, Jenny.
Jenny, muted?
I'm unmuted.
Now you are. It's okay.
Yeah. I was saying, I think that's great, Leonore. We should definitely, once we really launch and emerge.
Well, if you talk to our governor, we're launched.
Well, once we're comfortable fully launching.
I agree. I couldn't help be a little political.
Well, thank you so much, everyone. I hope that we'll do a little bit of editing. We'll reinsert the videos and take out some of the pause moments, but I think generally we have really most of what we need here. So I'll keep you posted. Yeah.
I think it's great, just great.
Wonderful.
And I remembered to press record. So enjoy your vacations, Lenore. Anyone else who's about
Thank you.
Deserved. Take care.
Great.
Bye.
Thank you. Bye-bye.